In this introduction, I would like to talk about three things. First is the origin of the $300 house. Second is what is our agenda for this 4-day workshop? And third is next steps. What is this $300 house all about? And why do we need a $300 house? Take a look at this fact. Today, there are 75 million people who are homeless in this world. 75 million. That's the size of United Kingdom. Who sleep on pavements, for whom sky is the only roof. Is this right? Even insects have homes, is it not? Even a spider has a home, is it not? Every human being has a right to have a home. So we start with a basic premise. Housing is a human right. And about 12 months ago, myself and a colleague of mine, Christian Sarkar, we wrote a blog in Harvard Business Review asking, why can't we build a $300 house for the poor? Now, where did we come up with this number, $300? And why did we choose the $300? Again, three reasons. One, if we just said, let's build a low-cost house, I don't know whether it would have galvanized people. There is something about the $300 price point that's kind of an attention grabber. Second, I read the book by Dr. Muhammad Yunus, the founder of microfinance. And he says, when poor people come out of poverty through microfinance, they are able to build a house for $375. So I kind of rounded it off and made it $300. The third reason perhaps is the most important, which is $300 is an aspirational goal. $300 price per se is not that important. What is important is what it stands for. What it stands for is, let's just set aside all our assumptions about housing. Actually, I don't know much about housing. And my wife is in the audience. She will be the first person to say that I don't know even how to handle, hammer and knife and nail. My naivete about low-cost housing may be my biggest asset, because I always ask the question, why not? It's nearly impossible to start with our current concept of a house, 4-bedroom, 3.5 bathroom, and try to scale it down to serve the poor. Instead, we need to take a clean slate approach. Let's assume we just landed in Mars. We know nothing about a house. Let's just build a house. Incidentally, let me make one point clear. $300 house does not mean we provide something cheap to the poor. This is not about low cost. This is about value. This is about shifting the price-performance paradigm. This is about providing a lot of value to the poor at very little cost. Do more with less for more people. In fact, the innovation paradigm, we have to change it from value for money to value for many. The way I look at ultra-low-cost housing is, how can we offer maximum value? Now, how is this possible? I don't look at the $300 house as a house, but I simply look at it as a metaphor by which can we offer more value in terms of more health, more education, more jobs. What do I mean by that? Take, for instance, health. Health is not provided just in hospitals. Health is delivered at home. Take, for instance, 3 diseases which are killing millions of people every year: tuberculosis, cholera, and malaria. Tuberculosis is an airborne disease. Imagine a hut in a slum which has no sunlight, no ventilation, which is the condition of most of those houses in slums, and 10 people are sleeping in that hut. If one of them has tuberculosis, it infects the other 9. So if you can somehow design a $300 house, staying within that price point, and provide better sunlight, better ventilation, you can dramatically decrease the incidence of tuberculosis. Cholera is a waterborne disease. You provide clean water, again staying within the $300 price point, you can dramatically decrease the incidence of cholera. Malaria is carried by mosquitoes. Again, staying within the $300 price point, if we can simply cover all the exposed parts in a hut with mosquito nets, you decrease the incidence of malaria. Take, for instance, education. Education is not delivered just in schools. It's also delivered at home. Take a country like Haiti. It does not have the same electric grid that we have in the US. Therefore, when the sun sets, bulk of Haiti goes dark. We cannot even imagine in the US living 50% of our lives in darkness. That means when sun sets, a kid in Haiti is not able to do his or her homework. Is it the fault of that kid? Is the kids in Haiti any less intelligent than kids in the US? If we can somehow stay within the $300 price point and use innovation and come up with an ultra low-cost, renewable energy-based electricity, we can deliver education at the house. My point is this: when you're trying to shift price-performance paradigm, the key is breakthrough innovation. And when innovation is involved, $300 house is not a question of charity. It's a problem for commerce. It's a challenge for commerce. Business has to play a central role because innovation is key. Businesses know how to innovate, they know how to scale, they know how to execute. But corporations cannot do this alone. They have to partner with NGOs, with governments. But more importantly, they have to partner with the poor. Poor should not be viewed as a passive beneficiary of a $300 house. Rather, they should be an active participant in co-creating the house. Poor must get a fair share of the value. We must practice inclusive innovation, inclusive growth. You see, corporations will take the $300 house very seriously if it is a legitimate business opportunity, not if it is a corporate social responsibility. Can the $300 house be a legitimate business? I say yes. Let's look at facts. There are 7 billion people on planet Earth. And estimates say out of the 7 billion, 4 billion need affordable homes. And let's say the family size is 4. That means we need 1 billion homes. And this population can actually pay a lot more than $300. But even let's take the $300. You do the math. We need 1 billion homes at $300 price point. That's $300 billion opportunity. No business can afford to ignore that. In fact, I am planning to write a letter to the CEO of Apple. Right now, 4 billion poor are not buying your iPhone. If you can innovate and come up with a $10 nano iPhone, I got a $40 billion market opportunity for you. Even the mighty Apple cannot ignore that. My point is, iPhone is not a luxury for the poor. Digital connectivity is not a luxury. It is a way we can deliver more value. We can deliver more health to the poor through telemedicine. We can deliver more education to the poor through e-learning. We can provide better access to financial services through mobile banking. We can deliver more entertainment to the poor by delivering music or movies or games. Corporations, converting the poor into consumers, I contend is the biggest opportunity for corporations. And they can expect a fair return in this process. There is nothing wrong in corporations making money by producing and selling a $300 house for the poor. There is nothing wrong in that, as long as they create more value for society. There is nothing wrong in corporations demanding a fair return, as long as they create value for society. In fact, I have not seen any human being who complains against a leader who appropriates value after creating value. In the 2008 and 2009 financial crisis, what we found was there were a lot of leaders who were appropriating value without creating value. In fact, in many instances, even destroying value. Business is a force for the good. Capitalism is the best system in the world, but we must practice responsible capitalism. We must practice inclusive capitalism. In fact, the biggest opportunity for businesses is to solve the complex social problems, be it affordable health, be it clean water, be it waste management, and of course, affordable housing. So 12 months ago, myself and my colleague, Christian Sarkar, simply threw this challenge. Why can't business, NGOs, governments come together and create a $300 house for the poor? We were really surprised by the response. The response was overwhelming. In fact, that blog took a life of its own. The response was so positive, we said, let's try to see how far we can push this. So we created a social media platform. You can actually go visit it. It's www.300house.com. And we invited anybody who is interested to join our community. We have over 2,500 people who are part of this community. These are not unemployed people. These are architects and engineers who are saying, how can we help? Then we said, let's really use the wisdom of the crowds and throw a global challenge. Anybody in the world can submit a design for the $300 house. And we got so many designs. And out of all those designs, we picked 6 winners. And those 6 winners have traveled from all different parts of the world and are here today. Maybe let me ask the $300 contest winners to perhaps please stand up. They're here somewhere. If you could just stand up. This is a kind of a nice segue for me into talking about what's going to happen in these 4 days. This is the prototype design workshop for the $300 house for Haiti. You see, housing is a very emotional topic, so we can't create a house for the world. So we've got to pick a geography, and we chose Haiti because houses depend on culture, weather conditions, etc. So we brought the contest winners, and then we have also invited architects and engineers from outside. They're going to work with Dartmouth students and Dartmouth faculty from Tuck School, from Thayer School, and from the college. So we have about 40 of us. We're going to roll up our sleeves. For the next 4 days, we're going to work on the prototype design. We are going to break the 40 members into 4 teams. 2 of those teams are going to work on designing the $300 house. When you build a bathroom, you prepare a design. That means a floor plan, the height, the building materials, etc. That's exactly what they will do. So 2 teams will work on designing a $300 house with a floor plan, building materials, cost estimates, etc. Why do you need two teams? One is going to focus on rural Haiti, another is going to focus on urban Haiti. Because the housing issues in rural areas and urban areas are fundamentally different. The third group will work on infrastructure and community development. The house is of no use if there is no clean water or there is no sewage. So the infrastructure issues is how do you work on water, sewage, waste management, etc. But also the community development is important. For instance, how do you create jobs? If you don't create jobs, then people will rent that house and move somewhere else. So we need to think about infrastructure and community development. So the first two teams will work on designing the $300 house, the third team on infrastructure and community development, and the fourth team will work on business model issues. That team will work on what is the size of the market, how big is this problem, what is the financial economics, how do you finance this house, what are the execution challenges, etc. This is the scope of the next 4 days. As next steps, once we have a viable design, we will take it and actually construct a prototype in Haiti. And the final step is, once we have a viable prototype, we will build a $300 house model village in Haiti. That's our aspiration. And we were thinking, we need someone to inspire us to kickstart this 4-day workshop. And I can't think of someone better than Dr. Jim Kim, president of Dartmouth College. He's the first Asian American to be president of an Ivy League. Dr. Jim Kim's credentials are absolutely impeccable. Valedictorian in high school, magna cum laude from Brown, then got his medical degree from Harvard Medical School, and also got his PhD in anthropology from Harvard. Anybody who can do medicine from Harvard Medical School and PhD in anthropology, they've got to be smart. And this hybrid, doctor and anthropologist, has really shaped what he has done. Particularly when you're focused on poor countries, delivering health, of course, involves understanding the medical science. But delivering health also requires you to understand the context in which people live. That's where anthropology comes in. You've got to understand poverty. You've got to understand sanitation. You've got to understand racism. Dr. Jim Kim co-founded, and subsequently he became executive director for Partners in Health, which provides world-class healthcare service at an ultra-low cost. Do more with less. To people in poor countries like Haiti, Peru, Rwanda. He was director in World Health Organization for HIV and AIDS department. Just before he joined Dartmouth, he was chair of the Department of Global Health and Social Medicine at Harvard Medical School. He received the MacArthur Fellowship. He was rated by the Time magazine as one of the 100 most influential people in the world. Do we need to say more? It's a real honor and privilege to have Dr. Jim Kim give us the keynote address. Please put your hands together and welcome Dr. Jim Kim.
Thank you, everybody. I'm really honored to be here with the winners who came up with the designs. I also want to welcome an old friend of mine, Patrice Neville from Haiti. We met many years ago, and he is one of the most important members of the Partners in Health team in Haiti. In Haiti, it's called Amis la Santé, which is just Partners in Health in Haitian Creole. And I also want to say I just sit on the board now. I do very little work in helping Partners in Health, but they were just ranked by the Global Journal as the second best NGO in the world, ahead of CARE, ahead of so many Médecins Sans Frontières, number 2 in the world. And you know, as someone who's now away from that, but can sit back and watch with great pride, I think it's the case. So what can I possibly tell? I know less about housing than Vijay, much less. And you know, Vijay just said hammer and knife by mistake. I actually use hammer and knife most of the time. But what I want to share, and I've learned it from Vijay especially. I mean, you know, my collaboration with Vijay since I've gotten here has just been fantastic. I've learned it from people like Al Mully, who heads our Healthcare Delivery Science Center. I've learned it from Bob Hansen in the back, one of the deans here, who really out of nothing built a program focused on healthcare. But the argument that I want to try to make to you is that all of us here in the room have a tremendous responsibility. You know, for so long, it seemed that it was enough just to want to do good in the world. That in fact, all the work that we do around the most important social goals, education, healthcare, sustainability, housing, that all of those projects were really a question of our personal moral commitment to the problem. In other words, the most important thing is to care about the poor, or the most important thing is to get out there and actually try to do something. But that's changed. And I think now we have much less tolerance for poor execution. Now, we still execute poorly, and I've said this again and again and again to people, and they're tired of hearing me say it. But when it comes to our most cherished social goals, it's not just that we tolerate poor execution, we celebrate it. It's a marker of our commitment to the problem that we don't know our budget, we don't know our outcomes, because it's really not about efficiency and effectiveness, it's about the depth of our commitment. I would argue that if you're really committed, you hold yourself to a very high standard of execution and outcome. Right? Now, when Vijay talks about the business world, some people have a complete misunderstanding, and they'll say things like, well, you know, they may all do things better in the business world, but they're, you know, running dog capitalists, all right? And they don't care about the poor, they only care about profit. Well, let me put it to you this way. Actually, most businesses don't do things better. Actually, most businesses do things very poorly. It's just that the market gets rid of them, and you don't see them after a while. But in the social sector, we last forever, no matter how poor we execute. And there's no place to understand that better than the American hospital system today. Community hospitals everywhere that execute incredibly poorly persist. Schools that execute incredibly poorly persist. Global health programs are now exploding all over the world, and the level of execution in many of those programs is awful. But they will say, no, we're not like those capitalists who think about efficiency, effectiveness. We think about moral commitment. If you're truly morally committed, you will hold yourself to a standard of execution that the poor would want from you. The poor, you know, students all the time over my 30 years of doing this work would come to me, and they would come to me having just come back from, you know, some poor country, and they're wearing sort of clothes that look like they came from that country, and they're wearing sandals, and I would say things to them that would shock them. I would say, you know what? The poor are not asking you to mimic them. The poor are asking you to use your connections to wealth and power to actually try to make their lives better. So this is hard. It's a hard lesson. You shouldn't, it's a wonderful experience to want to help and to go to these poor countries. But I would argue that the most important thing is to hold yourself to an extremely high standard for what you actually get done. Now, I'm going to talk a little bit about a little bit about Dartmouth, and a lot about my experience, particularly in Haiti and in Africa with HIV. And this is not about HIV, but it's about the lessons I learned from trying to tackle a particular problem. Now, it's hard for me to start a talk without showing this picture of one of the presidents of Dartmouth College. And John Sloan Dickey was president from 1945 to 1970. And in August of 1945, he was the head, and people in the room from Dartmouth have heard this, but this is for the 40 who are here from outside. In 1945, he was the head of public relations in the State Department when the United States government dropped nuclear weapons on Hiroshima and Nagasaki. He was the one who had to stand up in the State Department and defend that action. 2 weeks later, he was named the next president of Dartmouth College. And when he came to Dartmouth, he brought with him an incredibly heavy burden. He talked all the time about what it would take to create a generation of people who would prevent us from blowing each other off the face of the earth. And he said this at his first convocation: "The world's troubles are your troubles, and there is nothing wrong with the world that better human beings cannot fix." Now that's the statement that brought me to Dartmouth. There were members of the search committee, and I kept saying, wow, is that what you want me to do? Is that the point of being president of Dartmouth College? And knowing that I wanted them to say yes, they said yes. And it's about as good a model for how you run an institution of higher education as I've ever seen. Now, I'm going to talk to you a little bit about Partners in Health. And these are the places mainly that we work. I did most of my work in Peru, and the person who really developed that project over years is now a Dartmouth faculty member. Jaime Bayona is in the audience and has a lot of tremendous insights into every aspect of development. But those are the places that we've worked. So it's been quite varied. The prisons of Siberia and Tomsk in Russia, 3 countries in sub-Saharan Africa, Guatemala, Mexico, Chiapas, Haiti, Lima, Peru, but also Boston. You know, when we talk about global health, I always like to say, well, Boston also happens to be on the globe. And so we worked in some very poor communities in Boston to try to improve healthcare. And the way we did it was exactly what Professor Govindarajan has been talking about for years, reverse innovation. We took innovations that we knew were working in Haiti and actually brought them to Boston. And the outcomes in Boston's community of Roxbury actually got a lot better. Now that program has expanded, and I can talk a little bit more about that. But let's just take HIV. This is a map of the world by land area. You've all seen it. This is pretty straightforward. This is a map of the world by HIV/AIDS prevalence. Now, this is really important. That map has a lot of clues that are really important to understand how we've been able to tackle HIV. If you looked at the same map of malaria, North and South America and Europe would disappear. And because the market economies that can afford to pay for medicines disappear, there have been no new malaria drugs for many, many years. If you look at TB, the same thing. The market economies all disappear. So not surprisingly, we haven't had any new drugs for tuberculosis in a long time. In other words, without market forces, without an incentive, you don't have the drugs. But because there are enough people in rich countries who have HIV, the drug companies are constantly trying to make new drugs. Because even if you have 1 million or 2, and it's probably 2.5 million people in the rich countries now who have HIV, probably 35 million in poor countries who have HIV. But because there's 2.5 million, and because they have to take their medicines every day for the rest of their lives, huge market, huge incentive to make new drugs. So in a sense, the poor people living with HIV are lucky because they happen to have a cohort of people living in rich countries who also have the problem. When they disappear, the new drugs don't appear. So we in Haiti met many people who look just like this. Tatis, Joseph Jean, he still works for Versami La Santé. Yeah? And so he came looking like this with tuberculosis and HIV, and after a few months of treatment, he looked like this. Yeah? Now, the story is pretty straightforward. You know, when we were in 1996, those of us who were physicians in 1996, we saw these kinds of stories all the time. They called it the Lazarus effect of HIV treatment, and it really was. People who looked like they were dead, all of a sudden coming to life, putting on weight, doing really quite well. And we have people now who've been surviving for 20, 25 years on HIV medicines. It is one of the great miracles of our time. That's a topic for another time, but it is a fantastic story. And the story is so fantastic because it really started off with a small group of people. Right now we have as our guest Larry Kramer. I don't think Larry's here. Is he here? No. We have as our guest Larry Kramer, who was the person who started the group ACT UP. And ACT UP was a group of mostly gay white men, and they decided that rather than allow more and more of their compatriots to die, they were going to start acting up on every level. They took over NIH buildings, National Institute of Health buildings, threw blood on vaccine and viral researchers because they weren't focusing on HIV. They chained themselves to the White House gates. They took over buildings. They did things that were incredibly disruptive, but then got things moving. Money started going into the NIH for HIV research. They even changed the rules at the FDA so that if there was any promising molecule, it would immediately go into clinical trials. They shortened the period, the delay from finding a promising molecule to understanding if it was effective against HIV to getting it to market. They even changed that process. It is, I would argue, the most extraordinary story of activism being effective that I've ever heard of. And so this was 2003, but these drugs really became extremely effective in 1996. And what the ACT UP folks did, what this group of mostly gay white men in New York City and in San Francisco and some other places, but mostly New York City, what they did was to say, we put our bodies on the line to get these drugs made. Damned if we're going to allow them to be used only for rich people. So a group of the ACT UP folks started taking over buildings demanding that we have treatment for everybody in the world, that these drugs be made available for everybody. But for a long time it was some of the most powerful and important people in the world would say things like, you know, HIV drugs are too expensive. They were about $12,000 to $15,000 a year per patient. And it's just too complicated to do in a developing country. So Joseph Jeun's story, the before and after story of Joseph Jeun, was our way of trying to put the lie to that very, very common wisdom. Everyone said it. Some of the richest men in the world, and I won't name him, would say, I think in Africa we're talking about the next generation. Right? Now everyone's changed their opinion since then. The head of the US Agency for International Development at one point said, well, you know, these drugs are really complicated. You got to take them 5 times a day, which was not true already by then. You got to take them 5 times a day. And, you know, in Africa, they know morning, they know noon, they know the dark of evening, but they don't have watches. They can't tell time. How are you going to take medicines 5 times a day if they can't tell time? He actually said this in an interview with the Boston Globe, right? To which a group of Africans who he had just visited the month before, they commented, well, this particular gentleman came and visited us in Africa, and it's very surprising to us that he would say that we can't tell time because actually he was the only one that was late to every meeting. But in fact, you know, it's not true. It's not true. And right at this time, in September of 2003, exactly at that time, I had become one of the senior advisors to the Director General of the World Health Organization. I helped run his campaign. And when he, surprisingly, out of the blue, he's a Korean gentleman, when he won and became Director General of the World Health Organization, he invited me to come to WHO, and we launched the campaign. And it was from lessons. This is exactly, for Professor Govindarajan, it comes naturally. He knows that you have to have a concrete target, something concrete that people can work for. But those of us in medicine, we don't know this kind of thing. And a very good friend of mine, a guy by the name of Don Berwick, who until recently ran Medicare and Medicaid down in Washington, D.C., Don said, you've got to have a clear target with a clear end date if you want anyone to accomplish anything. So out of the blue, in the summer of 2003, we launched this campaign in which we said probably 50,000 people are on treatment in Africa right at that time, but we're going to get to 3 million in 2.5 years. 3 million on treatment by 2005. It was the most outrageous goal that, at least that's what everyone told me, that the World Health Organization had ever set. And so we launched into this. And we used Joseph Jun's story everywhere. We put it in every publication coming out of the World Health Organization, and Joseph Jun became a symbol for what could happen. Now, I'll tell you how much he became a symbol. In 2006, we went to the AIDS meetings in Toronto, and it happens every 2 years, or huge meetings, 20,000 people. And one of our team went to a poster session, and at the poster session was a group from Kenya, and the group from Kenya had Joseph's picture on their poster before and after. And the team from Haiti said, but wait a minute, that's Joseph Jun, he's from Haiti. I said, no, he's from Kenya. They knew his name, they knew the drugs he was on, and they said, no, this is Joseph Jun. I go, no, he's Kenyan. And so we had actually brought Joseph to the meeting to give a talk, and so they brought Joseph to the poster, and the Kenyans saw him, and they started crying, they took pictures together. But the point was, small things like seeing the possibility that a person who looks like he's African can go from looking like he's dead to looking as good as Joseph Jun looked eventually was an incredibly powerful symbol. I hear it again and again and again. People say, I saw those pictures, we thought it was impossible, and we began to believe that in Africa we could be successful in treating people. So what happened? Well, we missed the target. There were only 1.5 million people on treatment at the end of 2005, but we made it by the end of 2007. And when we launched the campaign, the people on my team at the World Health Organization kept saying to me, oh my God, this is so terrible. Why did you do this? We're really in trouble. And I said, what are you talking about? This is my team in the HIV/AIDS department. Oh, well, what if we don't make it? I said, so what if we don't make it? They said, well, then we'll be criticized. And I said, that's it? We'll be criticized? You would not take on an effort that might transform the lives of millions because you're afraid of being criticized? And they said, yes. In bureaucracies, you get criticized, you can lose your job. And so I said, you know what? If we don't make it, I will take all the blame myself. I will take every bit of the blame myself. I, in fact, did take all the blame myself at the end of 2005. And yet, what happened was, when I got out in front of it and said, okay, I take the blame, I'm sorry, but I'm not sorry to you people who said we couldn't make it. I'm sorry to the people we couldn't reach and the people who died because we didn't move quickly enough. And so then what happened was the entire world started reinterpreting 3x5. They started saying, whoa, we never would have thought that 1 million people could, or 1.5 million people could be on treatment in such a short period of time. In fact, the post hoc analysis is that never in the history of global public health has anything moved as quickly as 3x5, right? Now, I've just learned that there are 6.7 million people on treatment in the world. And I've also just learned that there are now many African countries, and again, Vijay knows this better than I, but are growing at 6–7%. I guarantee you that if we had taken the path where we would say everyone in Africa with HIV is dead, one, there would not be that kind of, the 6.5 million people would be dead, for sure. Because, the thing is, when it comes to aspirations for the poor, so many people think they're being smart by quote-unquote being realistic and saying, oh, come on, you can't do that in poor countries. But when rich people say that about poor countries, the outcome is that it's true. If rich people who control the resources, who set the goals, who set the targets, if they are cynical and, and they'll say, I'm cynical but based on experience. If they're cynical and pessimistic, that will be the outcome, inevitably. So I've spent my whole life being accused of being an outrageously optimistic person. But as I've said many times before, and this is the lesson that this taught me, the $300 house, you're going to hear a gazillion people making the most cynical comments about how they know that it's not possible. For those people, that actually will be the case. They will never be the ones who build a $300 house that transforms housing in poor countries. I was once told by my own staff member at WHO, you gotta stop talking about 3x5, you gotta stop talking about treatment, you're just giving people false hope. My own staff. Now I think Barack Obama had the best take on this. He said there's no such thing as false hope, there's just hope. And it turned out it wasn't false hope. But if this person had had her way, and she won the argument, in order to prevent us from creating the incredible crime of giving dying people false hope, they would have surely been dead. But instead, we have 6.5 million people on treatment. We have African economies that actually have a chance of growing because the people who were at the most productive age, from 18 to 50, who were the ones who were infected with HIV, are now living. So it's not all a beautiful story, of course, because as we got out into the world, we realized that you can start giving people medicines, but my goodness, procurement and supply chain management is a big challenge. So one of the interesting things that have happened is in the countries that are doing really well, the HIV program has led to the development of procurement and supply chain systems that are now improving the overall availability of drugs for the entire country. But it didn't happen everywhere. There are places where it failed terribly. And generally speaking, we still are living in the middle of what I would call a terrible implementation bottleneck. Right? So 6.7 million is great, but there are probably 20 million people who need it. You know, we're treating probably 300,000 or 400,000 people with drug-resistant TB, and we are treating people at all for drug-resistant TB because of the work of Dr. Bayona, who showed that it could be done at large scale in Peru. But there are probably 1 million people who need treatment. So we're not there. We're not to the point of actually delivering the things that we already have. So we have spent a lot of time, and this is what I'm working with Bob and with Vijay and many other professors here at Tuck, with Al, Molly. What we're trying to do is to figure out how to break through this bottleneck, and we're doing it by trying to understand in places where things work really well, or where things go really poorly. The Botswana mother-child HIV transmission program was actually a terrible failure, whereas the HIV Care in Rwanda program was a tremendous success. So by studying carefully, utilizing the minds of people like our Tuck professors, we are now beginning the process of trying to understand what it actually takes to break through the bottlenecks. And what we're learning is that it's just as complicated as we feared. Right? There's no such thing as once you have a tool, it automatically moves through. I mean, I think the Gates Foundation is doing fantastic work building all these new tools, things like vaccines and drugs. But if the bottleneck exists, there's no theory of hydraulics that will tell you that if you load up a bunch of new products on top of products that don't get to the field, that somehow those new products by sheer weight will flush the other products through the system. You still got to figure out how to actually deliver and how to actually deliver in a sustainable way. Now, housing is critical for health. And one of the things that we've always done at Partners in Health is that we've started with housing in many of the communities that we work in. But our houses are more because we put concrete floors in, and we haven't really been able to think about houses that would be much, much cheaper, that would be more effective, you know, wired for the internet, all these things that we're talking about. But housing is critical. Housing is not sort of an add-on to the health of a very poor population. It's actually a critical piece of it, in my view. So this is the idea. We start with a small drawing, but I just want to emphasize with this slide that all of these other entities are really, really critical. All of these other entities are just critical to making it work. It's not the structure. So let me leave you with some lessons from the field. First, unfortunately, there's no magic bullet. Probably the best global health product ever was the smallpox vaccine. Right? And you may know, some of you may know, that it's really the only disease we've ever eradicated in our history. We tried to eradicate malaria, awful failure. We've been at polio now for a very long time, and we're still, unfortunately, quite a ways from eradicating polio. But smallpox was eradicated. And if you ask the people, I mean, the people who were most critical in making that happen were a physician named Donald or D.A. Henderson, and one of my heroes and a mentor of mine, Bill Foege. And if you ask them, how did you accomplish that amazing feat of vaccination? The answer from both of them is, it was not a vaccination project. So what are you talking about? Of course it was. No, it was not a vaccination project. They would say it was an epidemiology and management project. So if you look at what they did in India, for example, the bullet, the vaccine is very effective. But how do you vaccinate everybody in India? They discovered that it was just not possible. And again, to go back to one of the most important ideas, I think, in the business world, this notion of reverse innovation that Vijay has given us, they learned in Nigeria. Nigeria was a place where they had actually stocked out a vaccine. And in Nigeria, they were trying to vaccinate everybody. But they learned that, in fact, they were just as effective if they didn't vaccinate everybody. But as soon as they discovered a case, they would go in there, vaccinate everybody in that village, interview everybody in the community to see if anyone had come to visit that village, go find them, and vaccinate everyone around them. It was called the Containment Strategy. And so in a situation where they had stocked out, they learned that this strategy might be useful. So in India, instead of vaccinating everybody, they adopted what they called the Containment Strategy. But it was even better than that, because it wasn't just, they didn't stop and say, okay, so vaccines and containment, that's what you do. What they also knew was that there were a gazillion complexities. So how do you recruit the people who interview the people who find out who's been there? And then when you do that, how do you go to that village? And how do you talk to those people? And how far do you have to vaccinate around those people? And so they basically put together a quality control system that would have made Toyota jealous. Exactly, it was exactly like a Kaizen, continuous quality improvement system. They would all go out to their villages, they would do their work, and they would be required to come together every month. And every time they came together, they would share small innovations in the field. Well, we tried this, and in fact, we found that it was better. And over months and years of doing it, they eradicated polio. Excuse me, smallpox. So the point was, the vaccine was just the beginning, but it was the brilliance around management, understanding local context, understanding people, that actually, in the end, brought us to the point where we actually eradicated a disease. Now, you know, malaria is very different. It's a very different kind of disease. But I would argue that for both malaria and polio, I think one of the areas we're falling down is that we're not being as brilliant as we could be in utilizing the brilliant insights of management to make it work better. Structure is just the beginning, I'm sorry to say. That getting the structure together, having a great structure is just the beginning, but I think you can all tell that this team understands that. They understand that context and sustainability are going to be critical. Also, as we're out in the field putting these housing units in place, you've got to think about how bringing that housing to the system will actually facilitate the improvement of other aspects of life in those settings. I just want to leave you with one thought. You know, at Partners in Health, we talked a lot about the importance of avoiding victory narratives. And unfortunately, if you look at the websites of a lot of quote-unquote relief agencies, that's what you see. You see victory narratives. Oh my goodness, we went in and we saw these problems and we did this and we did this and we did this, and isn't that great? It's really, really hard to avoid those victory narratives. They help you to raise money, and everyone is guilty of it in some form. Persistence in this task is required, of course. And I would argue that it only comes if you are persistently humbled. And in one way or another, your soul is fractured somehow by having the great privilege of coming from a very privileged background and getting to experience in some small way the enormous suffering of poor people. Now, you can see them in the field, and you see them all the time. People whose souls have stopped being fractured by the suffering of the poor. They're in hotel bars in the capitals of poor countries everywhere in the world. Somehow, they have stopped or prevented or moved away from having their souls fractured by the suffering of the poor through all kinds of mechanisms. And the mechanisms are as varied as the individuals, but it goes something like this. These people are poor because at some level they deserve to be poor. And every effort that I've made to lift them out of poverty has not worked. Therefore, there must be some deeper reason for their poverty. And you hear it all the time. The same people who are so cynical about us treating HIV, these are people who dealt with their probably early experiences of having their souls fractured by coming up with all kinds of reasons that it's not possible. In fact, there were people who were so angry at us because they were kind of looking at us and saying, damn it, if treatment of HIV were possible, we would already have done it. Who the hell are you to come and tell us that something that we know to be impossible is possible? Unfortunately, that's the world that you're walking into, and I would put it this way. Now that you're here, and now that you've signed on to this project, I'm sorry to tell you that you're in it deeply, and it's not going to be over for a very long time. The problem of housing for poor people in the world today is one that's going to be with us for a long time. But I really believe that this is doable. And you've got to not only believe that this is doable, but you've got to believe it in the face of so many of those people sitting in bars, in hotels, in the capitals of poor countries who tell you that it's impossible. Because after all, if it was possible, they would already have done it. We need people like all of you, we need people like Vijay to enter this world. And we need you to do it, not because you think that this is your expression of your compassion for others, but because the humility you feel in the face of the suffering of the poor makes you feel more human than at any other time in your life. Thank you very much.
Do we have time for
Of course,
a few questions?
Sure.
Any questions, thoughts for Jim?
Is there an opportunity for people other than the people that you've just introduced to be part of this 4-day workshop?
The way the mechanics of the 4-day workshop is going to work is we have invited 40 people, and that's really not open to public. We are just trying to roll up our sleeves and get to work. And I really appreciate your volunteering it. There'll be other opportunities when we open up and get more feedback. So right now we want to just get the design, but then we will have opportunity to get feedback from others, and certainly welcome that opportunity.
If I can, I've just been down in Haiti for the last 2 years, and I've built buildings down there. And I won a national award down in Haiti for designing some of the buildings that are down here. And I think I have a very intimate, close sensitivity to exactly what Jim Kim just described, and 2 years hands-on construction experience. If I can help, I would love to help.
Shall we just have a brief conversation at the end of this presentation? Wonderful. Other questions?
What is the job opportunities you created for the future people? For the people by the
Yeah, so Joseph June, for example, he's one of our community health workers. Now, we've worked with community health workers for years and years and years, and we find that the community health workers going out and actually interacting with patients every day, making sure they're taking their medicines, helping them solve various social and economic and other problems, we found that they have a huge impact on outcome. And there was an article in the New Yorker, a very famous American publication, that talked about how some clinics in the United States are using essentially community health workers. And of course, it was talked about as a great discovery that the Americans had made. And those of you from developing countries know that we've been using them for years and years and years. And so often what happens is that community health, the people who are cured of their diseases, we give them jobs as community health workers. And it turns out that we're now in Haiti, I think, Patrice, I think we're the largest employer in all of Haiti right now.
Yeah. Susanna here from years. I actually have a question about the delivery methods for a lot of your drug strategies, because I wonder, like, how many different kinds of models did you look at before you would go into a country, and how did you evaluate before making a decision on which to sort of try out, which would work in a particular instance? Like, if we're thinking, I'm an architect, and we're thinking about sort of building delivery methods, we all have experience and we all have exposure to different sort of technologies, and we have to kind of step away from that in a way when we're working in different contexts. But we all have this kind of baggage that we come with. So, like, how do you make the evaluation on sort of what the first steps might need to be?
Well, one of the things that we do now, for example, a big chunk of the Rwandan HIV care system was actually built by our Haitian colleagues. Right? So we were asked by the Rwandan government to provide technical assistance, and what we did was some of our most experienced leaders in Haiti actually went and lived in Rwanda for a while. And the system in Rwanda looks quite different than the one in Haiti. But when you have people who've had such experience on the ground building these kinds of systems, it worked. There were some general principles. For example, a constant argument that we've had with the tuberculosis crowd, and Dr. Byron knows as well. There are people who want to use technology, purely technology, to ensure that people are taking their tuberculosis medicines. And I still get emails every day from people who say, I've got this new system, it's going to work. Right? But what we've learned over many, many years is that community health worker programs are not only good for patients because they have that direct contact, and that sometimes it's not just having a pill and having, because these are punitive systems. If you don't take your medicine, we can tell you. That is much less effective in our experience than having actual people going out and developing relationships. Because, and if you look at if you talk to our folks in psychology and brain science, they'll tell you that in fact that's how to get good results, is to have people who are actually with you in your commitment to taking drugs, for example. You do better, or you lose weight, or you do all these things better. So in fact, some of the very naturalistic lessons that we learned in the field, it turns out that the psychology and brain science people are now telling us that in fact is the most effective way to motivate others. So part of it is just long experience, but there are a lot of just very basic principles that seem to work together. Now, every time you have a community health worker project, that means that your outcomes get a lot better and people are employed. You really do get 2-3 birds with one stone with that particular approach. Now, in terms of architecture, I mean, there are organizations like Architects Without Borders. I suspect that there's a lot of wisdom out there, but the reason that we're here trying to build the field of healthcare delivery science is that while those little tricks that airline companies do to be more effective are published everywhere, the little tricks that people know to keep poor people housed or to keep poor people healthy, there's no field that tackles that issue. So we're trying to build it. Incredibly, in the social sector, there is no field that does any of that. So in other words, if you were a principal and you wanted to build a great K-12 or an elementary school, where would you go to find that sort of list of all these tricks and principles that are critical to building a great elementary school? The case studies that show why the Harlem Children's Zone is so effective. Where do they exist? Where would you go to study that? It still doesn't exist, because the field of how you actually execute successfully around social goals doesn't really exist yet. Right? There are a lot of people writing PhDs and papers on very specific aspects of K-12 education, but that kind of knowledge doesn't yet exist. what I hope happens is that as you go forward, that this group will begin to establish that field. How do you do that? And you know, part of it is, you know, you go to Médecins Sans Frontières, Doctors Without Borders. They have a lot of insight into how to work in the field. And none of it, very little of it is written up, and certainly not in any kind of systematic way that compares their, you know, operations to, for example, successful operations in other companies. That's the field we need. The science of execution around social goals is a field that we need to build. And for housing, my sense is that this could be the start.
Okay, we are, question? Question?
I did have a question. One thing that struck me, Vijay, was when you said the component is listening to the voices of the poor themselves and getting their input. And I was wondering how you were planning to do that and whether that would even be part of it. Or were you going to bring the house and then get input?
What we have done is we sent 2 field visits to Haiti, a team of architects and engineers and students. Twice we went to Haiti to understand what the customer problem is, but we have also invited people from Haiti for the workshop. So both those inputs would be useful in design. But when we actually go to build the prototype, again, we will involve the locals. So it's very, very important that people who are going to use the house actually co-create it.
Really, it's a critical point. You know, in Haiti, in Peru, so many places, we've had people who come to the field and they know that their technology is going to revolutionize everything. Let me just give you an example. Solar bread ovens, all right? Years ago, we had solar bread ovens. And it might be a good idea, but you know, people who are, some of them were starving, would say, we can't eat this. Bread sucks, right? It comes out of the solar bread oven, right? And yet they kept coming back and kept insisting that, you know, it was their technology. So, you know, at Partners in Health, we talk about making a preferential option for the poor. And that's the way that Catholic priests in Latin America have talked about it. It's a very fancy way of saying you really, really, really got to listen and know that it's about them and not about you, right? So we say often that a preferential option for the poor is very different from a preferential option for your idea, right? Preferential idea for your solution to the problem. And that's a very, very hard thing to get over. Because in the face of unbelievable poverty, you want to feel that the only reason people are so poor is because they haven't yet benefited from your great ideas, right? It's so difficult to deal with that vastness of poverty that people use all kinds of psychological mechanisms to deal with it. And this is just one that we have to avoid. And I have to tell you, it's built into Vijay's idea from the very beginning. So.
The paradigms of the inputs to the technology or the design in different parts of the world will be different. So when we talk about, say, Haiti as a initiation, how do we scale it up to different parts of the world?
It's a great question, and I think this is another interesting thing about the $300 house. It is a simple statement, but it masks the complexity. And part of the complexity you're saying is house has to be different from one region to another because of availability of building materials, affordability, culture, weather conditions, etc. So we fully recognize that. Therefore, the scaling will come. We need to think of a core design that can be scaled, but then there are add-ons that can be used in a modular form to customize it. I don't have all the solutions, but that's one concept we can use. But this is a great question because ultimately scaling is critical because this is a global problem. And yeah, so, and scaling also brings the cost down. So this is another reason I say corporations should be involved because they know how to scale. But we don't know the answers, but that's an important question.
So our experience from 3x5 is setting an extremely bold, seemingly impossible goal with a very short time frame. What happened was that the intensity of activity around trying to reach that goal taught us things, uncovered weaknesses and problems that we never would have if we would have said, let's get a lot of people on treatment as soon as we can, right? It's different from saying 3x5 and saying, let's provide good housing. It's different from saying $300 house now, right? And so I think the fact that the target was set the way it was bodes very well for this project. But again, my sense is this is the field we have to build. How do you scale low-cost, high-tech, great housing in the world? That field, as far as I know, doesn't yet exist. We can build it, starting with this particular project. Yeah.
I just want to comment on Dr. Kim's speech. I think it's, especially towards the end, it's really touching, and I think gives me especially a lot of strength, because I've actually encountered a couple of those very angry professors.
Yes. Who say you can't do it. Right. Yeah.
So I just want to comment on this really helpful and influential right now for us going forward.
Thank you.
That may be a good place for us to wrap up. Anyway, we are almost coming to the end. There are so many messages from Jim's talk that I can highlight. But one thing that really stands out for me is thinking bold. 3 by 5. And in some sense, we are in extremely difficult conditions, not just in the US, all over the world. I think when resources are tight, this is the time for us to think bold. Austere times calls for audacious goals. And we have to think of building a great nation. If our aspiration is to build a mediocre country, that's the best we are going to do. So we got to start thinking of how we build a great country, and that sort of propels us to think about, sort of face this most fundamental question, why not? And probably that's the most powerful lesson that I have taken from your presentation. Clearly, you would agree with me that both directly and indirectly, Jim has saved millions of lives all over the world. He's a true inspiration, and I certainly feel very blessed to know him for the last 12 months, and he is probably the perfect person to get us started on the $300 house project. Please join me in giving him a big hand.
Thank you very much. Thank you. Thank you. Thank you. Thank you. And good luck. Good luck. This is you're starting something really important.
Thank you, Jim. And just to maybe just as a wrap up, the 4-day workshop is not open, but if you want to find out what we accomplish in these 4 days, certainly you can ask me. But there are also a couple of individuals here. If you run into them, you can ask me. There is Molly Board, if you could stand up. She is a Dartmouth undergrad. She is the global health officer in the Health Delivery Science Center, Healthcare Delivery Science Center. There is Vicky May. Is she? Vicky May is here. There, she is a professor at the Thayer Engineering School. There is Nitin Sharma. Oh, Nitin is right at the back. He is a second-year MBA student at the Tuck School. And above all, Jack Wilson. Where are you? And Jack has put an incredible amount of time in making this happen, and certainly he's another person you can reach to. But most importantly, I think all of you coming today is a big boost of energy for us. I received so many emails supporting this initiative. This is such a worthwhile cause. We've got to put our collective thoughts together and solve this complex and wicked problem. And thanks for all your support. Thank you.
Congratulations.